The duodenum represents the most challenging and difficult site for endoscopic resection compared with other areas of the gastrointestinal tract. This is due to anatomical features which include a narrow lumen, a precipitous flexure that causes poor stability of the endoscope, Brunner's glands in the submucosal layer that stiffen the duodenal wall, resulting in poor mucosal lifting, a thin muscle layer that results in a higher incidence of perforation and increased risk of other complications such as delayed bleeding and delayed perforation, and difficult access if emergency surgery becomes necessary. Endoscopic submucosal dissection (ESD) is regularly performed at expert centers in Japan for superficial lesions of the esophagus, stomach, and colorectum. ESD achieves a higher proportion of en bloc resection, which enables accurate histopathological assessment. Duodenal ESD, however, is exceptionally difficult technically, and the procedure is associated with the highest incidence of perforation, with serious consequences compared with other sites in the gastrointestinal tract. Meanwhile, endoscopic mucosal resection (EMR) is a safer, easier, and quicker procedure compared with ESD. However, EMR results in fewer en bloc resections. Although there is still controversy as to which endoscopic resection method is preferable, EMR is currently recognized as the standard procedure for endoscopic treatment of non-ampullary duodenal tumors. Duodenal tumors such as primary duodenal adenocarcinoma and duodenal adenoma are rare compared with other gastrointestinal tract cancers, and consequently there are no established indications for endoscopic resection. The necessity of en bloc resection is controversial due to the procedural risks in this region, and there is no definition of early cancer or pathological criteria for curative endoscopic resection. Duodenal lesions that require endoscopic resection are so limited in number that although several reports have been published, most involve only a small number of patients. Consequently, there are a number of issues that need to be addressed in the future. In the study entitled Clinical Outcomes of Endoscopic Resection of Non-Ampullary Duodenal Tumors, Nonaka, Satoru et al. Make a retrospective analysis of the clinical outcomes and assess the feasibility of endoscopic resection as a therapeutic procedure. Patients and methods. A total of 113 consecutive patients with 121 non-ampullary duodenal tumors underwent endoscopic resection by endoscopic submucosal dissection (ESD), endoscopic mucosal resection (EMR), or polypectomy between January 2000 and September 2013. Long-term outcomes were investigated in patients with more than 1 year follow-up. Results. The median tumor size was 12 mm, range 3 to 50 mm. Lesions consisted of 63 adenocarcinomas, high-grade intraepithelial neoplasias, and 57 adenomas, low-grade intraepithelial neoplasias. Endoscopic resection included 106 EMRs, 8 ESDs, and 7 polypectomies. En bloc resection was achieved in 77 lesions, and 43 lesions underwent piecemeal resection. One procedure was discontinued due to perforation. There were 14 cases of delayed bleeding after EMR, 1 perforation during ESD, and 1 delayed perforation after ESD which required emergency surgery. Of the 76 patients who were followed for more than 1 year, none of the patients died from a primary duodenal neoplasm, and there were no local recurrences during the 51-month median follow-up period, range 12 to 163 months. The authors conclude that duodenal endoscopic resection is feasible as a therapeutic procedure, but it should only be performed by highly skilled endoscopists because of its technical difficulty. Based on excellent long-term outcomes, piecemeal resection by EMR is acceptable for small lesions.